Partnerships and E-Learning at Mental Health America's National Office, and I'll be helping to moderate today's session. I have just a few notes before we get started and hear from our panelists. This webinar is being recorded and will be emailed out to all registrants within 1 week. We currently do not offer CEUs, but if you would like to request a certificate of attendance, you can do so. We have a form you can fill out and that will be emailed to you. I'll post that form in the chat here shortly, and that will also come in your follow-up email. So if you miss it in the chat, that's okay. You'll get it again. As I stated, your cameras are off and mics are muted. They will stay that way, but we encourage you to use the chat today to ask questions, post comments. We want to thank all of our panelists for joining us and for our sponsor today, West Fraser, who has been working to support Mental Health America in our work with rural mental health, which is sponsoring today's session, and we'll also have another session in October. So if there are certain topics that you want us to explore further in that next session, feel free to add any of those suggestions into the chat or through your questions today. Ask questions about things that you're interested in. We might have some time at the end of today for some questions with our panelists. Otherwise, we'll be sure to address those in our next session. And with that, I want to welcome our panelists with us today. We have Shauna, Ray, Chuck, and Larry, 4 individuals who all are working hard in the mental health space and also have experience in rural areas. Welcome, panelists. We're so thrilled to have you here today with us, joining us for this topic. I'd love to just start out with some introductions. If we could hear from each of you, tell us a little bit about yourself and let the audience know who you are and what you're bringing to today's conversation. Anyone who wants to start us off can.
I will start just for the sake of time. Hi, everyone. It is great to be with all of you today. My name is Shauna Reitmeyer, and I have the honor to serve as the CEO for Illuma. We are a certified community behavioral health clinic in Northwest Minnesota. So we are very rural, very frontier. And then I also serve as the president for the National Association for Rural Mental Health. And so it's a pleasure to be with all of you and to share some of our perspectives of providing services in rural communities, and then also being someone with lived experience of myself individually that sought my own mental health care along with family members from that perspective as well.
I'll go next. Excuse me. I'm also very glad to be here, and I quickly ran through the chats and saw that I have some fellows from Virginia, so that's wonderful. I'm Larry Merkel. I'm a psychiatrist and an anthropologist at University of Virginia. I'm our director of outreach, which means I deal with all of our telepsychiatry, all of our outreach to other communities, and I've been working in Central Appalachia for 20-something years doing telepsychiatry as well as trying to build treatment programs there. And I'm glad to be here and I hope to share with you my experiences. Thank you.
Hi, my name is Chuck Strand. Thanks very much for the opportunity to be here. I am the executive director of Rural Minds. We are the only national 501c3 nonprofit that is focused on specifically serving the folks who live in rural communities across the country with free information and resources specific to addressing and confronting the challenges that surround mental health in rural communities and the greater stigma that surrounds mental illness. So thanks for the opportunity, and looking forward to the conversation.
Hi, everyone. My name is Ray Scott. I'm the executive board president for Students with Psychosis. And I'm also a student at Ohio State University pursuing my bachelor's degree in social work. And I come from the lived experience perspective as well. I've dealt with mental illness and lived in a rural area most of my life in Ohio. I've lived in Columbus the past 3 years, but most of my life was spent in a rural area.
Thank you all so much. And thank you for spending time with us this afternoon together. Each of you brings such knowledge and perspective and experience that we'll get to dive into. So, first, I'd just love to hear a little bit from each of you about your experiences with mental health in rural communities, how maybe it is or isn't discussed, how you normally find out about resources available. Are they talked about? Are they not talked about? And just your kind of general observations of the topic of mental health in rural areas.
So I grew up in a small town in northern Michigan near the shores of Lake Superior. So I'm very familiar with living in a rural community and can appreciate the challenges and the shortages of access to mental health professionals and the distance you might have to travel. In addition to, right now we have many people in the country who don't really have reliable internet access. So even telemental health is challenged. But I think, some of the unique, in addition to like the structural and geographic distance and differences between rural and urban, the other big difference is just the lifestyle that the barriers that come with living in a rural area. And a lot of times at the top of that list is the fact that people who live in a rural community are often very independent, and that sometimes is necessary if you're, doing a job or just having to survive without having the opportunity to dial somebody to roll up in your driveway and fix your pipe or whatever. You need to figure it out yourself. And I think with that mindset, when that's coupled with something that can be as stigmatized as addressing a mental health challenge or an illness, it becomes really difficult to reach out for help. So we see that as something that's unique to rural communities. And one of the programs that we've developed is specific to meeting people where they're at and recognizing that self-reliance as an attribute and giving people the information that they need to do it themselves to the extent that it's possible, as far as having conversations and breaking down the stigma by talking about lived experience, which is so important to have people realize who may be struggling and not able to talk about it, that someone they know in their community is sharing their story, doing something to break down the stigma, and it makes people realize they're not alone, and that a mental health condition or an illness can be managed effectively. So that's all really important information as far as people sharing what they can with each other, with peers.
And if I could maybe piggyback, I'm really glad, Chuck, you used that word independent, because that's something that I have really um, been honing in on. And from where where I'm from in Northwest Minnesota, we're a very agriculture focused region. And when you think of independence and we think of farmers, farmers are the planners, they're the veterinarians. If you happen to have cattle, you're the you're your accountant, you're the mechanic, you're the everything in your farm, right? That you're doing. And so it is an unknown that people would think, well, if I, half the time, if I'm in the middle of fixing something and I cut my arm, unless it's life threatening, I'm going to throw some duct tape on that, right? And go back to business to finish what needs to happen. And that's the same mindset of like, oh, I kind of feel off my mental health. I might feel a little depressed, but you know what? I got this. I can do this on my own, until we start seeing that, boy, that farm, that neighbor that I've driven by that's had this, everything is done, things aren't repaired anymore, things aren't, taken care of. There's, the grass is growing or hard to get out. You start seeing some of those things because there is that mindset that I should be able to take care of this all by myself. And so one of the things that, we're seeing as well is prior, probably to 10 years ago, if not even like 6, we didn't really talk about mental health, right? It wasn't promoted, it wasn't discussed. We didn't have marketing campaigns that promoted mental health. I and now I think we're starting to open the door with more conversation. It's challenging in rural areas. So where I'm at, we're the only mental health provider in the 6 counties that we serve in Northwest Minnesota. So there aren't options or choices, right? And so we're feeling that it's our responsibility as an organization to make sure that the community knows that there are services and to help them think about their head is attached to their body and there's that interconnectedness. And if they're not going to come to us, where do they go? They go to their primary care doctor sometimes. We reach out to the wives, to the moms, they're the ones that are often making appointments and helping talk about what some of those services are and how to access those. And, I could go on and on and on, around that. But I think that um, we have to recognize that there always aren't a lot of options. And there's also this, we use the word stigma. I'm channeling my good friend and colleague that says, really, we're talking discrimination. People have fear that they're going to be discriminated against because they have mental health issues. And when you're in rural areas, somebody drove by, they know my vehicle, right? Oh, you're parked outside of a Luma. Like, okay, what is, oh, that's what that is. I think it's changing a little bit now. We're seeing a lot more conversation happening around mental health and partnering with different entities like public health that's really trusted in our community. They're taking a strong role around being able to do some of that outreach and engagement. So I'm going to stop talking though to give the floor to some other people, but yeah, we're coming along, but we still have a long way to go.
I agree with that. I would say that in my experience, both dealing with mental illness myself and within my family, that it's often something that was not discussed until there was some sort of catalyst or something that forced us to address it. And even then, once the conversation came up, we found that there were little resources and programming, and we would often have to drive over an hour to get to an appointment. And especially when it comes to things like specialized treatments or specialists in the area, those just weren't really an option for me at the time. And I find that that's regularly the case for those who have especially severe and persistent mental illness. And I'd also like to bring back to the point that Shauna brought up about discrimination, because I've found that at times it can be unsafe really to talk about mental illness, things from bullying and harassment to even assault. And especially for those who have other intersectional identities along with their mental health. So it's something that is very starkly different from the urban area that I live in now, and that I feel more safe in not only to have those discussions about mental health, but I feel like the overall view of mental illness is less monstrous. Like I felt very heavily judged in the area that I lived in for having psychosis. And I don't experience as much of that judgment now living in an urban area.
Um, for for me in working in Central Appalachia, much of what you all have said is pretty true as well. People there tend to be also very independent, self-reliant, but very reliant on the family too, and large clan structures. But we have counties where there aren't even physicians, not much less any sort of mental health services. And there's also extreme poverty too, unlike some other rural areas. And there are some farms and some cattle farmers and such, but so many people are engaged with extractive industries. What coal mining there is, what timber collecting there is, both of which are extremely dangerous and life-threatening. And so there's some differences there. One of the issues that I'm particularly interested in is that often mental illness gets talked about not as mental illness, but as nerves, as bad nerves, broken nerves, frayed nerves, and this probably is in other areas, but it's the common dialect for talking about these kinds of issues down there, which often gets misunderstood by uh, people, trained physicians that think of it in a different way. So it's important to understand those cultural differences too, which I think is one of the questions that comes up. We certainly do have a lot of stigma that comes from two sources in many ways. One is the thing you all have mentioned about expecting each other to be very strong, independent, and that not being able to carry out your functions within the family, whatever those are, is threatening, and you can be ostracized for that or looked down upon. And often one of the causes for that, not the only one, but one of them is mental illness. And so nerves actually gives a way to experience that without necessarily the stigma of mental illness. The other issue is many of the people are very strongly fundamentalist Christian, where it's expected of Christians to be happy, and to be depressed or to have these kinds of problems often indicates that you've strayed away from the right road and that you need to get back to Jesus. And it's often dealt with that way as well, which can make it very hard. So and most of our work is through primary care providers because there's less stigma showing up at as you all were saying, at your primary care provider's office than going to the local mental health center like that. And so that's one way we've gotten around it. But when we are dealing with so many things, with the poverty, the physical ailments from this strong, hard labor that these people have, the breakups of the family, the opiate crisis has quadrupled all of our issues. One thing that's sort of come out of it, though, is that there is now more money being put into trying to find care for people and linking mental illness with substance use disorder. But it's a very complicated issue.
Absolutely. Thank you all for providing your own perspective and experiences and those of the individuals that you're serving. I have been reading through the comments in the chat as well, and it seems like a lot of what you've shared has resonated with folks in their own communities, and they've experienced a lot of the same things that you're talking about. Um, I know we've talked a little bit about some of these kind of cultural and social norms in rural areas, and I'd love to kind of dive into that a little more. What are some of those specific cultural and social norms that might be contributing to stigma in your areas? And I know that some people have already pointed out some things in the chat that they've experienced, and you've all shared some of those kind of the self reliance, that resilience, those different things. But is there anything else on that you'd like to share?
I'd like to share something, and it's actually a question to our panelists too, because I think that part of the challenge with any mental illness, and it's not even specific to rural, is the fact that unlike other diseases that are illnesses such as diabetes or cancer or cardiovascular disease, people that are experiencing mental illness can experience some of the same situations that are common with someone that feels anxious or has a bad day or depressed. So the people that are receiving the information from someone who may be struggling with mental illness or a challenge, perhaps they think that they can relate to that because everyone has a bad day, and some of the advice that people get who don't understand a mental illness, such as, sleep on it, you'll feel better tomorrow, or suck it up, or whatever it might be, and but I think part of that is just because it's not, mental illness is not recognized as an illness, and people can relate to it to a certain degree, but really have no insight into the severity of some of the illnesses that you can't really experience unless you are suffering with that illness.
Larry, I would really, you from a physician perspective, I think, but I think the thing that I've been seeing in the reading, so not only do I get to run this organization have my own lived experience, but also am a therapist and have, continued to do the work. So much of what we're doing now in this integrated healthcare approach is really helping people to start recognizing the somatic responses that people are having to their mental health. Physically, what are they feeling, and how mental health can come out, like I would like to say, it comes out sideways, right? It comes out in this way if it's not addressed over here. And why we always talk about, like, the head is attached to our body, and we're all one, and so impacted to that, and so I don't know if I'm, answering that question, but I think the more we partner and we're working with primary care, often that's where people are starting. And it's the relationships we're building with primary care physicians that now start referring to us, because they know they're showing up with somatic issues, people with mental health, and they know there isn't anything over here. Let's work on the mental health. And so then that almost becomes a normalizing conduit. If primary care is normalizing this is mental health, yeah, let's come on over here because my doc or my PA or, NP has said this is important for me.
I think it's absolutely essential in the rural areas, at least where I am, that primary care providers very much need to be brought in, because as you said, they're often the only providers for everything. They deliver babies, they fix broken arms, they do everything. And unfortunately, most of them have not been trained in any sort of mental health. Very few get any sort of psychiatry experience in their residencies. So they are faced with dealing with these conditions and just sort of going by maybe a little bit of what they've read or what they've heard. So not only is it important for us to be there for them to refer to us, but also for us to be there to help educate them so that we're working on these kinds of things together. And in Central Appalachia, it really involves the whole community, mental health providers, the primary care providers, but also the teachers, the mayor, the church leaders, if they're at all interested, which many of them unfortunately aren't because they're focused on other kinds of things. But because there are so few resources, and in order to turn things around, it really requires a very large approach involving anybody that's helpful and interesting. One of the things I've noticed is that often in small little communities, there'll be one or two people that are doing some wonderful work. They're finding jobs for people that have come out of jail, or they're helping people to find resources for mental health, and they're just doing that maybe through their church or through maybe their the local club or something. And yet, if there's a way to connect them with other people that are doing these same kind of things, to not just have a community-wide support system, but a regional-wide support system is really so important, because the resources are so small. We need to fill those gaps and help other people pick up their share with it. And so primary care doctors are very important to that, but there's also a whole lot of other people as well.
Absolutely. Thank you all. And just on the topic of some of those norms, I saw a lot of comments in the chat too of communities kind of a norm being alcohol and drug use as coping, or another norm is just a lot of people in the same religion. Lots of small town gossip, or not feeling like you can get away from people knowing your business. I think those are all things that are continuing to perpetuate stigma, or there's some opportunities in some of those spaces too to start to really combat the stigma. And as Larry, you started to bring up with education, I'd love to kind of dive into that a little deeper with everyone, and kind of shift our conversation now from recognizing what stigma is and looks like to what can we start to do about it in our communities and in these rural areas. So I'd love to hear from you all about what role you see education playing in reducing mental health stigma, and any strategies that you've seen to be effective.
One of the things we found is the ECHO program. I don't know if people know about that. It originally was a way to train primary care doctors how to do specialty care, but it's expanded way beyond that. And we are doing echoes with first responders. We've got some plans for doing it with PTA groups in order to expand knowledge in the community about these kinds of things. And that's certainly a good place to start. I don't think education is going to turn things around by itself, but it's a very important thing. And doing exactly what you're doing here is so important to try and get the word out there to help people see what it's like, that people that have psychiatric problems are not dangerous necessarily or something to be afraid of, that they're just like everybody else. They're just like your brother, your sister, anybody. So.
And to just maybe add to that, Larry, I think it's a multi-pronged approach, right? I think there's a lot of opportunity that we could be trying to advocate for is more going upstream. And the more we can help educate and teach our young people just around emotion regulation and recognizing, just how are we feeling and what those just normalizing that there is mental health as early as we can, because the more that they become aware, we may have an opportunity to intersect and possibly prevent serious mental illnesses down the road if they're not addressed early on. But we also have a need. So I think of like, where do we start as young as we can to then understand and recognize where we really have the serious illnesses to address? Because so much of mental health, I feel, if we could really intervene as early as possible for people with depression or anxiety, that could be really kind of addressed early on, that won't become serious down the road, right? But if untreated, the more issues and the more functioning and challenges people have, then it's harder for people to find that recovery path if we were able to start a little early. But then you've got folks now, right, that do need help, and having that education and awareness around what resources are available and how to access them. I also think programs like mental health first aid, or question, persuade, refer, or assist when it comes to suicide prevention training. I think of, it was very unfortunate in our area. We had a death by suicide in our community, but what we were able to, I saw somebody say the Men's Shed program, love that, right? And so, but we had a death by suicide, but what we were able to do was to partner with our local civic groups, the Lions, the Rotary, the Knights of Columbus, the Masons. And actually what they did is they all chipped in money into our community to bring training to our community around suicide prevention and mental health awareness training that was then formed. Now what we have, our Hope Coalition, a multi-county coalition of people that formed to bring in education and awareness, because it takes everybody, not just one person or one entity, but it starts with one. It starts with one person to help build that. So
I think that education is really important in reducing mental health stigma, but I also believe it's important to emphasize that it's not enough. There's definitely more that needs to be done. And I think that empowering and resourcing those who have lived experience is definitely key in helping those in rural areas. Things like peer support can be very transformative. And I also think that a big part of the stigma in rural areas that I've experienced, at least, has been an over-reliance on authority, I would say, because there's a lot of police involvement. I know where I lived, there was no like alternative to like being in an emergency mental health situation, a mental health crisis, other than calling the police. And that can be very dangerous for people who have mental illness. I've been in dangerous situations with police myself. And I think that taking control away from authority and giving it to the community can be helpful and empowering, not only those who have mental health diagnoses, but also those who are caring for them, those who are friends, family, in the community as well.
Along the same lines, as far as connecting with people in the community, I think that really speaks to another challenge, which is that people in rural communities typically want to get information from someone they know. They want to look them in the eye. They want to be able to shake their hand. They're not as trusting in the media. And with that being said, it really speaks to the solution of making a real impact in rural America. It has to be person to person. And really, when you think about any major movement that has happened or is happening, it all comes down to one-on-one conversations and interactions. And so really, again, as far as I saw some of the chat comments, as far as we need more resources, and not that, there's Rural Minds is all about partnerships with so many organizations, and including, of course, MHA and NAMI and a lot of other organizations, whether in the mental health space or rural focused. But part of what we do is provide access to an easy, efficient way of like a roster of different free resources that are available to the public. And it's classified by either by crisis, mental health crisis, of course, 988 at the top of that list, in addition to topics alphabetized. And so all that's on the website. But the resilience part of it is really important back to the person-to-person connection, because part of meeting people where they're at is giving them as much or as little information as they're comfortable or want. And with the Rural Mental Health Resilience Program, people can go on to find what they're interested in. If it's just top line education for themselves to understand more about mental health conditions, or some of the statistics that surround mental health, mental illness, which is part of what we do is lead with we're not all about suicide, but that's of course the most drastic, tragic situation. But people in rural communities are 64 to 68% more likely to die by suicide than people in major urban areas. And that's a stat from the CDC, which is truly shocking. So there is an emergency, but we don't want to leave it at that. It's important to recognize that. But then what can people do to be part of the solution? And that's really the point of that program, where people can pull down the information that they want or need, do something as simple as printing out a flyer about the program that mentions that emergency stat, but also links to the program and provides people with access to get the tools, the information they need, so they can be part of the solution, to have tough conversations. Like, how do you start some of those awkward conversations, or how do you manage a situation where someone might need help, and where do you go for those resources?
Thank you, Chuck, and thank you, panelists, for all sharing the different resources you're aware of. I love in the chat everyone sharing things that they know and use, so that hopefully those in different communities have something that's popping up that they might be able to access that's new to them. One question, Larry, I know you had mentioned the ECHO program. We had a question in the chat, if you could share a little bit about what that is.
It started in New Mexico, University of New Mexico, where they were having a terrible high mortality from hepatitis, which in New Mexico, of course, is incredibly rural. And the hepatitis clinic at University of New Mexico was just overwhelmed. There were people dying on the waiting list before they could get treatment for hepatitis. So they decided, well, what we can do is train primary care physicians how to treat hepatitis, especially in the rural areas. So they built a sort of a consortium with many of their primary care rural providers, and started a webinar kind of like this, where for 20 minutes there might be some didactic education about what are the best drugs for treating hepatitis, how do you understand the different liver enzyme measures and these kinds of things. And then the rural people would present a case to them, and they would discuss that case as further education. So there was very much a bi-directional kind of effort. And worked beautifully, and the hepatitis mortality rate dropped down. And then they started applying it to other things like substance abuse, behavioral mental health, and maybe like 20 or 30 different diseases now. And it's all across the world doing this thing. And we do it, as I said, in Charlottesville, in Virginia, and we're focused on mental health, substance abuse, cystic fibrosis. We used it to do trainings with people working in Black lung clinics. And as I said, we're going to use it also for working with members of PTA committees or first responders or other people. It's turned out to be and it's also expanded now where it's not only is it these small groups of bidirectional learning, but you can also do a large webinar first and then break it down and do bidirectional learning. So it's much more, where it started off as a very focused kind of thing, it's now very broad and is shown to be incredibly effective and helpful. Yeah.
Thanks, Larry. That's really helpful. I appreciate everyone sharing those resources, Chuck, Shauna, Larry, and Ray. And I know one of the things that has come up time and time again throughout our discussion today is the message of community and needing to get information from trusted, valued sources, that person to person that you brought up, Chuck and Shauna. I'd love to kind of talk about how community leaders, people in those positions of power or authority that people trust, or just community members that are kind of those central hubs of knowledge. How can we utilize those people within communities to help combat stigma and start to share these types of resources?
One of the best ways to do that is with community health workers or community mental health workers. Who are people from the community. Many of our peers have had lived experience, but they're known by the community, and they maybe work in tandem with the primary care provider, but then they go out in the community and they sort of know who's having trouble and who's suffering and can talk with them. And they're, as far as anybody knows, they're just sort of sitting on the porch gabbing. So Kentucky has a state budget line supporting community mental health workers and community health workers, and they've done research on it, and it's been a very empowering and fabulous program. So that's often a way to go, but that takes resources. They have to be trained, they have to be supported. Then there also has to be then resources for them to refer to when they find people that are hurting. But that is a very powerful way to do it at sort of the local community ground level.
Mhm. So if I'd piggyback, Larry, on the community health worker, is also when I think of certified peers or peer recovery specialists as well, I think are another great resource. And one of the big pieces that has been really instrumental for Aluma over the last several years was when we became a certified community behavioral health clinic. So I like to always emphasize the community part in that title because of one of the core responsibilities that we feel is so important is the engagement and coordination and partnership with community. So often, and in one of the ways, I won't go into the detail, but a fundamental component of this is how we get paid. And through the payment mechanism, it allows us to have some outreach and educational resources within our organization. So often we are the conduit. So I go back to that authority piece, Ray, is that often we are the conduit of helping to convene and or apply for other funding that goes out to the community to support. So we might get it and it's helping, the overall mission and that outreach, but we are also helping to put resources to schools or into other community events or activities that are promoting that education and that awareness, and it brings the partners together. Because in rural, we can't do it alone. We have to partner together because there just aren't enough resources. And it really is about building relationships for a shared goal or a shared purpose. And when we start talking about these are our loved ones and our neighbors and our friends and our family, that, you know, people, we get connected to what's important, and that's what brings some momentum in our communities as well for building that awareness and relationship building.
Jackie, in response to your question about what leaders and communities can do, I would suggest that they provide a platform for people to share their lived experience, and not that everyone can do that. It takes a special person who has the courage to step up and talk about something as highly personal as managing a mental illness or a condition. But I think that the combination of someone sharing the lived experience, in addition to having a mental health professional, ideally, kind of partnering together on a presentation, whether that's in person or virtual. You know, and back to that program, we've got TED Talk key messages as far as the mental health resilience program, also slides. But we really encourage people to use that. And on the flip side, in addition to being appropriate for leaders in a community, we also recognize that anyone can become a leader in the community, and just by stepping up and taking the platform for talking about mental health and the stats that recognize it as a crisis, and also the solutions. And but the shared experience with people love stories, and by sharing a personal story, it really helps to normalize the conversations and lets people know that they don't need to be alone, and they can effectively manage a situation with a mental illness or a challenge.
With the issue of leadership, government leadership is really important. One of the things Virginia has expanded so that peer support people, peer counselors, can actually bill Medicaid now, which is allowing them to be independent. So that I know with peers, there's often this, well, if I work with another institution, that maybe I'm not so much a peer anymore. There's often a tension there, but being able to bill Medicaid allows them to be very much independent, but then work with other people. And that's a really good program that we need to support them. And leadership, government leadership, state leadership, and national leadership. The cost to the United States of mental health, mental illness, and substance abuse is greater than the cost to the United States of cancers. And yet the amount of money that goes to mental health is like a tenth or less of the money that goes to support cancer. So we have stigma, if you want, at that level where the priorities, I think, are somewhat, not that, I mean, I'm a cancer survivor, so I don't want cancer treatment to go away, but we need to have more parity in these kind of things. So grassroots is really important, but we also need to get government people to make an effort in this area as well.
And Larry, since you were talking on that from a federal and a funding perspective, I think there's also this this notion of structural urbanism. Most policies and programs and evidence-based interventions that are out there, you know, have been developed and implemented from a mindset of where the majority of people live, and those are in your urban areas, right? And they're not putting into context, what is it like in the rural areas? And we've got to start having a rural thought and rural perspectives. It's my dream, right? This utopia that any mental health policy will have a rural perspective to it, right? That it will take into account what's needed in rural areas, as opposed to it all being, you know, driven off of where's the majority of people for testing evidence-based interventions, and from that perspective. So you know, I think we've got some opportunities to really push that. And that's one of the big focuses from the National Association for Rural Mental Health that we keep talking about when we start advocating for policy. And I was really excited to see in the congressional budget, there was language put in there specifically around rural focus needs to be addressed in that behavioral health bill. But boy, we'll see where that ends up going, right? You know, it's not passed, and not going to go down that path. But I think that's we have to start making those bold advocacy points and decisions to make sure 90%, 97% of the United States landmass is rural, right? When you think about where the majority of our country is, we are living in rural areas. And so we need to make sure that that voice is heard. Get on my soapbox.
I'd like to echo the sentiment earlier about bringing like a personal lens to the conversation on mental health in rural areas. I think that bringing some humanity to that conversation can help those who are struggling with the idea of a loved one having a mental health condition. And I think that driving things away from institutionalization a bit into more peer-led spaces like peer respite, peer support can be really crucial. I know that for me, getting involved with students with psychosis was absolutely just the best thing for my journey, because it being in a rural community and growing up so isolated, having suddenly a lot of peers who I can connect with and who understood me was really important for my own mental health. But it also helped my family in understanding me better, which improved our relationships and also their understanding of mental health. When other family members of mine presented with mental health concerns, they didn't have necessarily the same experiences that I did that were quite negative.
Yeah, thank you for sharing that, Ray. And I know we had another question in the chat specifically to you that I'd love to hear your perspective on, Ray, as a young person. Someone had asked, how do you think younger school-age persons can approach their parents or caregivers to really get them to understand their need for mental health services, or maybe what did that look like for you?
Yeah, so I think this is a difficult question because, like I mentioned earlier, in my situation, it felt like it had come to a point where we were forced to talk about it because I was struggling with things like self-harm, suicide attempts, and it just got to a point where it was something that you couldn't not notice. But I would say that when talking about mental health with family, with loved ones, if you are able to get someone as a support person to have that conversation with you, that can be really helpful. I had a previous partner of mine have some tough conversations with my family and myself about mental health, and that quite literally saved my life at one point. So I think that if you can have that support person, that can be great. But also, I recognize that there are some people who are so isolated that they may not have that support person to lean on. And I think that, unfortunately, I think that there are times where you have to be your own advocate and you're the only one who can do that. So I would say to please not give up on yourself when you're having these tough conversations. I think persistence is very key when it comes to education. I don't think that one conversation is always enough. Most of the times I wouldn't say it's enough. So I think being persistent about that and believing in yourself and what you need and coming to that conversation with a certain confidence can help people understand that what you're talking about is not just that's necessary, that your mental health and caring for yourself is necessary.
Thank you, Ray. I appreciate you answering that and being so honest and vulnerable with us. I'm sure those listening really appreciate that too. I know this hour has just totally flown by and we only have a little bit of time together left, but I'd love to just end on a note. I know a lot of people that are joining us here are living in rural areas, maybe relating to a lot of the conversation personally, and maybe are struggling with their mental health right now. So I just love to end with panelists. If someone listening today is experiencing that and is scared to reach out or not sure what to do, what would be your advice to leave them with today?
I think that the introduction of 988, the three-digit calling code, is so important because not only is it a resource for someone that's experiencing a mental health crisis, anybody can call 24/7 with a question. You don't have to be in crisis. You can ask the trained counselors who answer the phones. Your question is totally anonymous, and since some of the challenges for people in rural communities is the fact that they feel isolated without having the opportunity to speak confidentially to somebody, 988 is a nice option because pretty much everyone has a cell phone and it's an easy number to remember and it's always there.
I would say you are not alone. There's many people walking probably a very similar path, not the same. We each have our own lives, but are walking a path. And I think about, and this doesn't apply to everyone, but think about, is there one person that you could call? Could be 988. It could be a sister, it could be a friend, it could be a colleague, and or those natural places, right? It does. It takes a lot of courage to pick up the phone, to reach out and ask for help. And that's that little critic on our shoulder telling us, oh, you can do this on your own. But why do we have to do it on our own when we can walk side by side with someone? And I can almost bet if you've reached out to somebody, they won't leave you hanging. They're going to help you. They don't probably know, but you're not alone.
I would like to echo that, Shauna, and I would also like to say to anyone who is scared to reach out that it can be extremely difficult. Um, and it took me a long, long time to believe in this idea, but your life does matter. You deserve a life that's as rich and satisfying and full as anyone else. And if there's nothing else that you take away from what I said today, I want you to believe that. I want you to know that if you've been mistreated, if you've been discriminated against, that you did not deserve that, that you have to believe that you deserve better and that you are worth it and you will always be worth it. So that's what I have to say. Thank you, everyone.
Thank you, Ray, and thank you all. I know we're right at the end of our time, and I just want to give a few reminders before we wrap up. But before I do that, Chuck, did you want to share briefly? We have another learning opportunity from Rural Minds coming up that we wanted to give you all information about.
Yeah, thank you, Jackie. So we have another webinar coming up on Wednesday of this week. That's part of our Connections webinar series. And this one is about the impact of the Inflation Reduction Act specific on new treatments for mental illness. So we're really excited about it. It's at Wednesday at 1 p.m. Eastern Time. And there's more information about it and pre-registration on the Rural Minds website, which is ruralminds.org, ruralminds.org. And there's also, when you get to the main page, there's a link from the banner to the web page for the webinar. And there's also recorded content from all the webinars we've had previously. So please check those out, and hopefully they're helpful and interesting. And if we can do anything else, please let us know. Thank you.
Thank you, Chuck. And I just put the link to that in the chat, and we'll also send that out in your follow-up. Thank you all so much for joining us, for your rich questions, comments, resources in the chat. I know a lot of you put in some really great resources. I'm going to be looking through the chat and compiling all of that to send out afterwards, so we make sure that nothing gets lost from the chat. I know we had lots of questions about that, but just a reminder that this was recorded. We'll send it all out to you along with those resources within 1 week, along with our speaker contact info. So if you want to get in touch with them about any of the programs or information that they shared today, you'll be able to do so. But thank you, Shauna, Chuck, Ray, Larry, for being here with us for this last hour, for sharing your knowledge, experiences with our group. It was a really great discussion, and we're looking forward to continuing this discussion in October with another West Fraser sponsored webinar. So thank you all panelists.
Thank you.
Thank you. Everyone have a wonderful rest of your day, and keep an eye out for our follow-up email where you can check out all of our resources and the different resources shared today. Thank you all.